Okay. Is that okay?
Sir, okay, sir.
Maybe, yeah. Maybe
Sir,
the
Pandian
light
sir
is...
is joining. I think we can start, sir. Pandian sir is joining shortly.
Okay. Go ahead. Maybe.
Sir, good evening, sir.
Good evening. Yeah.
Good evening all.
Good evening, Jay.
Good evening, sir.
Good evening, sir.
Good evening.
Through ஆரம்பிச்சிடலாங்களா?
அது ஆரம்பிச்சிடலாம் நான் ஒண்ணும் இல்ல. Just give me
I
30.
think you start, Piru. You can start,
Yes,
Piru.
ma'am. Yes, ma'am. Just give me 30 seconds. Okay. Good evening, everyone.
Good evening, sir.
Good evening, sir. It gives me a great pleasure to be part of the 4C series, which is mainly targeted at addressing some of the common cases which we see in our practice. Let me start today's program with the pediatrician's prayer. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய நிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுவான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ. Now, I now request upon our President, Dr. Suren Palan sir, to say a few words before I can pass the baton on to our academic coordinator.
Good evening, sir. Good evening to all, and my respected the Secretary of our IAPTNSC, Dr. Thirumurugan, Treasurer, Dr. Dakshayani, the Academy of Pediatric Sciences under the Presidential Action Plan for this year 2023, the coordinator, Dr. Rajendran sir, and the convener for this 4C series, which has started, and this is the 5th session on headache, more headache, which is a very, very important practical topic. And I want to place my appreciations and congratulations to the 4C team, the convener, Dr. Aswad sir, Sridevi madam, Balaji, as well as Palani Raman sir, for the wonderful efforts along with Dr. Rajendran in selecting the various topics which are very necessary, very practical to each and every one of us. And ever since this series started, it has been showing off very well, going on very well, and I think it is being viewed by many all over the country also. And today we have an excellent team of moderators, great stalwarts in pediatrics, Professor Dr. Ramasamy sir from the Masonic Medical Center, Coimbatore. He is a teacher of teachers, clinician of clinicians, and we are very happy for him to join with us today as a moderator, as well as our teacher. Thank you, sir. And as well as our teacher and the neurologist whom I have seen as a pediatric neurologist ICH for so many decades ago, Dr. Pandian sir, is a very simple and very practical person, excellent clinician in neurology. He has also taken efforts to join us as one of the moderators, as well as the great teachers, Professor PRC sir, Professor Kannan, Janani Shankar madam, Dr. Raju sir, and all the various presenters who have joined today, the EB members, the CAAP members, all the pediatricians, postgraduates, everybody. This will be very useful for them, and the way the discussions are going, the way the presenters are presenting, I really place my appreciations and congratulations to each and every one of them. I hope this will go a long way to the practicing pediatricians as well as the postgraduates to build up their knowledge in pediatrics and up to date their knowledge in pediatrics. Thank you very much for this wonderful opportunity. Once again, my congratulations to 4C team. Thank you very much.
Thank you very much, sir. Thanks for your encouragement and your vision in coming up with a program which is suitable for everybody's needs, from postgraduates to the primary care pediatrician. May I now request upon our Academy Coordinator, Academy of Pediatric Science Coordinator, Dr. Rajendran sir, to say a few words and then start the program.
Thank you, our dynamic secretary, Dr. Thirumurugan, and I respected our president and he's a very dynamic person, Dr. Suresh Balan, and President-elect Dr. Balashankar, and President past Dr. Ramesh Babu, and our Honorary Secretary Dr. Thirumurugan, and Treasurer Dr. Dashani, and all the central as well as state EB members. On behalf of IAP-TNSC, I welcome one and all. It is fifth 4C series, and it's really going very well. And today's moderator, sir, Dr. M. Ramsamy, I think he's none other than he's a very dynamic person. He's currently advisor, medical advisor, Masonic Medical Center, and he was my mentor and guru also. I welcome Dr. M. Ramsamy, sir.
Thank you very much, Dr. Rajendran. Thank you.
I welcome Dr. K. Pandian. He was a well-known neurologist, as well as he was a former professor of pediatric neurology, ICH. I welcome Dr. Pandian, sir. I welcome all the 4C series team, program convener, Dr. Aswath Doraisamy, Dr. Sridevi Narayanan, Dr. Balaji, Dr. Palniraman, Dr. Raju, sir. And I welcome all the presenters, Dr. Palniraman, sir, Nitya Lagan, sir, and Parthasarathi, Dr. Sanjivida, Dr. Purnima, Dr. Janaranjani, Dr. Sasyanand. So I really vast experience, and as well as all the teachers are here. And once again, on behalf of IAP-TNSC, I welcome one and all. Now it's hand out to Dr. Aswath Doraisamy, program convener.
Thank you. I think I will not waste more time. It's just that any success of any program depends on the support that one receives. So we have received overwhelming support and blessings from both the central team of TNSC IAP and our dynamic visionary, Dr. Rajendran, who's been at the forefront of keeping electronic education alive for undergraduates, postgraduates, and for practicing pediatricians. So kudos to your efforts, dear friend. And without wasting more time, I think we'll start off with today's evening's deliberations. Thank you. Can we have the first presenter?
Who is the first presenter? Bus or Putukla?
Dr. Janani and our team had already opened the slides.
Purnima, okay. Purnima.
I think the first presenter was Dr. Palniraman, but I think who
Yeah,
are
I'm here. I am here, boss. I'm here.
Yeah, that means you can open it.
Okay.
Yeah.
Open
Sir.
it up. Okay.
Yeah.
My slides are visible. Hello.
Yeah,
Okay.
yeah.
Yes, Maninaman.
Yes, sir. A very good evening, everyone. Very good evening, my teachers, Professor Ramsamy sir and Pandian sir and everyone, and PRC and everyone are there. It's a nice evening, nice academic evening. We'll hope for the nice academic evening and the brainstorming session on headaches. To start with, this is a child, a 9-year-old girl who presented with a headache. Okay. A 9-year-old female child presented to me with a headache of 1 week duration on one fine evening. History of presenting illness, the headache was insidious in onset and bifrontal, and otherwise she was not able to characterize. Only 1 hour after awakening in the morning and associated with nausea. There was no precipitating or aggravating or relieving specific factors, and no other symptoms suggestive of local causes like sinus or ophthal or dentition, anything is present in that patient, and no history of migraine in the family. This was the first visit. On examination, the vitals were stable, BP was normal, and fundus was normal. And neurological examination, no focal neurological deficit, and sent home with the paracetamol and to maintain the headache diary. Since it was the first episode, I thought, okay, no need to go further in detail. Since there were no red flags, I sent home along with the paracetamol to give SOS and to maintain a headache diary for a period of 2 weeks and to come back to me. What happened after a period of 10 days, she again came along with the parents, both the mother and father. Initially, only father came. Now the mother also came. And this time, the parents complaining the headache has increased in intensity. And for the past 48 hours, she is having excessive sleepiness and complaints of double vision. That was the complaint which they came. And she was drowsy and on exam and no difficulty in standing or walking, and no history of any precipitating factors like fever, head trauma, ingestion of native medicine or contact with TB, etc. was present in the patient. So on examination, but she was conscious and responding to oral commands and moderately nourished and not obese. She was around 28.5 kg and BP was quite normal. The other vital signs, pulse, respiratory rate and everything was normal. Central nervous system, higher mental functions normal. There was a squint and features of left lateral rectus palsy was present, and DTR was brisk and plantar was flexor, and the fundus showed bilateral papilledema. So here the very vital features were the headache along with the that is lateral rectus palsy, squint, and along with the bilateral papilledema was there. So we thought the patient is having a red flags now because of there is a localizing neurological signs. Number one, there is a papilledema. These two are all the red flags. So we thought mostly we are dealing with some sinister lesion like intracranial space occupying lesion, because these are all features of raised intracranial tension. So we thought we will evaluate for the thing. So we had, yes, sir.
Anna, can you just take a break here?
Yeah.
Okay.
Ask Dr.
Yeah,
Professor Ramasamy, what are the points in history that each and every pediatrician should elicit to know what are the red flags upfront in the history, sir? What is essential history taking in a child with headache?
See, basically, the persistence is one. The intensity is another. Persistence and intensity. And then also the nature of the headache. And additionally, systemic manifestations. And so the persistence, severity, intensity, and if the acute severe headache and severe headache persisting, then I think, that headache cannot be ignored. And that should be pursued further to look for either intracranial or extracranial pathologies. That's how I would look at it. Here is a situation where the headache started more or less in a very mild or modest degree, but subsequently progressed to a little bit more severe. But more importantly, there were manifestations suggesting ICT, so increase. So this is a situation which I would definitely pursue further without any delay. He mentioned about the blood pressure, which is very good, because the blood pressure is an elevated blood pressure is a very important, a finding, systemic finding that sometimes could produce headache. He mentioned that as a normal blood pressure. Okay.
Dr. Pandian, would you?
I agree with Dr. Pandiraman and Dr. Ramasamy of what they have said we should watch out for. But I thought the first instance, one thing which we always teach is, if the child has been otherwise well, and if the child gets up in the morning with a severe headache, I think that should be a warning sign. Whenever there is a headache which presents for the first time in severity, and if the child especially gets up with the patient awakes with a headache, I think that should be a warning sign at the beginning itself. This is a child which I think has evolved into papilledema now. I think the warning signs have already been told. And if the headaches are consistent lateralizing with a definite papilledema, I think we go ahead and investigate for a intracranial lesion.
Dr. Pandiraman mentioned something about a headache diary, sir. Can you please elucidate what are the points that we need to keep?
The location of the headache, severity of headache, the type of headache she is getting, whether it is pulsating or throbbing headache, or it is very severe, and whether it is associated with any visual symptoms, and the duration. Say they can keep a time duration, 1 hour or 2 hours or 3 hours, whether it is relieved by drugs or not, or whether it is relieved by a simple sleep. I think that will be helpful in knowing the nature of headache and the frequency of headache.
Sir, one small point. Will all headaches, regardless of etiology, respond to paracetamol or some other NSAID? Will the response to the medication give some clue about the etiology?
Not always, sir. Some headaches continue to persist in spite of paracetamol, especially like cluster headaches. They don't respond to paracetamol as well as to other drugs.
Dr. Aswat, the usefulness of paracetamol is perhaps when the headache is a mild or modest degree, when associated with systemic illness, where you have a cytokine release, systemic illness, systemic symptoms like fever, then it is part of a systemic infectious process. In that situation, perhaps, very judiciously, one may use paracetamol, not as such relieve the headache, to give overall comfort to the child. So I don't think we can use relief from paracetamol as really a diagnostic clue or a useful clue to decide, the etiology of the headache. I don't think that is sensible to do it.
Point taken, sir. Right. Thank you. Dr. Paniraman, you can proceed now.
Another important point I want to mention, apart from the BP and fundus and neurological examination, we have to look for the cranial bruit. There was no localized cranial bruit on examination, because it is sometimes AV malformations can have with the sudden throbbing headache and sudden presentation. So here there was no bruit also.
1 second.
Yes,
How
sir.
is the gait, Paniraman?
Gait, she was not ataxic, sir. She was not ataxic.
Right.
Yes, sir.
No, I won't be surprised. I know he's going to tell us about this, the imaging findings. Imaging actually doesn't show anything intracranial. Yeah, then the question of benign intracranial hypertension comes. But the diagnosis that you make only after looking at the imaging. You don't make the diagnosis before looking at the imaging, because the priority must be for a intracranial space occupying lesion. If the imaging is completely normal, you do think in terms of benign intracranial hypertension.
Okay, sir. Thank you, sir. Thank you, sir. On investigations, the basic investigation, because to rule out any underlying infection, CBC, CRP was normal. Another supportive investigation, LFT, RFT was normal. And the MRI was done immediately. And the MRI findings were suggestive of papilledema and no evidence of space occupying lesion. And mainly there were perioptic sheath edema was suggestive of mainly a papilledema and optic nerve involvement. Otherwise, there was no evidence suggestive of deep central venous thrombosis. Also was MRV also was done. There was no evidence of central vein thrombosis. And this patient was admitted having the mind in diagnosis, as Professor Ramsamy sir told, mainly since papilledema along with the normal MRI. So mainly to rule out benign intracranial hypertension. So immediately CSF was planned, and the CSF was done with in a proper setup in a lateral decubitous position, and without in a relaxed posture, relaxed atmosphere, and the opening pressure was more than 34 centimeter. If it is more than 25, it is very significant, suggestive of increased CSF pressure. And the other CSF parameters with respect to cells and protein and sugar and other microbiological investigations were negative. So, and the final diagnosis was made as a case of that is idiopathic intracranial hypertension. And even after doing the CSF itself, LP itself, the patient's symptom like particularly headache and the double vision was improved much by doing the LP itself. And over a period of time, the child was started on a specific drug like acetazolamide in this patient. And after a period of 1 month, and everything, the papilledema, everything settled, and the child was followed for a period of nearly 1 to 2 years for any recurrence. And specifically, mainly this is more prone for the visual field defects, and visual problems are more prone. So done by a proper ophthalmology evaluation, the field perimetry, everything done, and there was not much amount of visual field affection. And the vision was good. At the end of 3 months after evaluation, to rule out any field defects, no recurrence and follow-up. And this was a child. Actually, hope Dr. Pandian Sal will be remembering. I referred this patient around 4 years back, sir. You only deal with afterwards. This is a patient. I referred a girl.
Yes, sir.
Under Professor Jananis unit, it was admitted and everything, sir.
We had a fundus photograph.
Yes, sir. Yes, sir. Yes, sir.
Dr. Aswat, I will tell you, the first time I ran into the almost 25 years ago, this benign intracranial hypertension presenting almost not identical, very similar to what Dr. Palindram done. That's why I said if the MRI were to be normal, it could still be a benign intracranial hypertension. And of course, no, but general pediatrician must refer these children to pediatric neurologist. Very important. You simply can't make a diagnosis without making a referral to pediatric neurologist, and you must go to imaging study also. That must be done, because before you write it down as benign intracranial, as rightly pointed out, in CS the pressure would be increased, and then the course is eventually recovery and then very benign outlook. The pathogenesis etiology are not fully understood.
Dr. Pandian?
See, the peculiarities in this case is the child has started off with a sudden onset of headache, which is a little uncommon with the benign ICT. They slowly develop a headache and it becomes intense over a period of time. Second, the child is presented with a false localizing sign, the left lateral rectus palsy, which can be a false localizing sign, but it is not very common in benign ICT. And he also said there is a nystagmus. Am I right, Pandiraman?
No, sir. Only strabismus, no nystagmus, sir.
Only strabismus. Okay. And
practice when nalgesic acid, interferon, and the other traditional drugs which cause pseudotumor cerebri are more or less not used in practice. Before calling it idiopathic, are there a checklist of drugs or toxins that we need to rule out as pediatricians before we label it idiopathic?
we no longer use high dose vitamin A. I think we were considering vitamin A as in those days. Steroids, high dose steroids. I don't think the child was exposed to high dose steroids. And there is no question of oral contraceptives here. And the other toxins I have not come across, sir.
Vitamin A, vitamin D, and hyperthyroidism.
No obvious endocrinal causes also, sir.
And, good evening, Pandyan, sir. Another.
Good evening,
sir. There are few false localizing signs. Even papilledema, you can take it as a false localizing sign. It does not point you to any focus. And in such situations, are we justified, especially in the periphery, to do LP?
After MRI.
Sir, LP papilledema per se is not a contraindication for a lumbar puncture, sir. And especially in a younger child, and especially in a setting in our country, I think we should not miss an early infection, probably even tuberculosis or any other viral infection. I think if you detect early, you have an adequate treatment facility available. So I think they are justified, sir. If you have a good anesthetist to help you out, papilledema is not a contraindication for LP, lumbar puncture, sir.
No, Dr. Aswar, no, this is risk of radiation with the lumbar puncture, especially in the presence of papilledema. Actually, the LP must be done with a three-way stopcock. See, many people don't do that because if you put a three-way stopcock, you let the fluid go up the vertical tube, controlled. So you don't really run into a sudden drop. See, as pointed out Dr. Pandyan, it is extremely important that infections are identified and diagnosed very early. And so I think, one should not unnecessarily postpone looking at a CSF study just because certain false localizing signs are there. But now with an imaging now comes to your rescue. Now imaging is available everywhere. It can be done very quickly before doing an LP.
Right. So the take-home message is, even if there are features of raised intracranial pressure, if there is no obvious evidence of coning or imminent cardiorespiratory compromise, we should do a guarded LP with a pressure manometer and a stopcock to regulate the flow of CSF rather than let out a lot of CSF and risk herniation. Thank you. Thanks so much, sir. Thanks, Dr. Pandiraman, for that very nice case. Can we have Dr. Purnima's presentation next? Dr. Purnima, are you ready, ma?
Thank you, IAPTNSC, for the opportunity. Thank you very much. Thank you.
Well done, Pandiraman.
Excellent, Pandiraman.
Dr. Purnima, please. Dr. Purnima.
Yes.
Good evening, sir.
Please share your slide, please.
Hello.
Go ahead. Go ahead.
Yeah, proceed. Proceed. You can go for a full screen.
Slideshow, yeah.
Yes, sir. Good evening to one and all present here. I'm Dr. Purnima C from Janani Ma'am's unit from Kanchi Kamakoti Child's Trust Hospital, here to present a case on headache. So this is a child, Miss P, 4-year, 8-month-old female child, second born of non-consanguineous marriage, 2 previous spontaneous abortions in the mother with uneventful neonatal period and developmentally normal for age, immunized up to date according to the IAP schedule, with nil significant past history. She came with complaints of headache for the past 2 weeks and vomiting for the past 10 days with increased preference to sleep for the past 10 days and deviation of the left eye noted by the mother for the past 2 days associated with double vision and history of fever and ear pain 15 days back for 1 day. The present complaint started an apparently normal child has headache for the past 2 weeks, which was progressively increasing in intensity, disturbing sleep and daily activities, associated with photophobia, no diurnal variation, not relieved with analgesics, not associated with aura, and no family history of migraine. Complaints of vomiting for the past 10 days, which was 1 to 2 episodes per day, non-projectile, non-bilious, and not bloodstain. History of fever and ear pain 15 days back for 1 day, undocumented fever, which was not associated with chills and rigors, and intermittent, relieved with medications. It was associated with increased preference to sleep for the past 10 days and deviation of the left eye was noted by the mother for the past 3 days associated with double vision, for which she was evaluated elsewhere and CECT brain was normal. In view of persistent symptoms, she came to our hospital for further management. On examination, she was conscious and
Dr.
oriented.
Purnima, can you just take a break, please?
Yes, sir.
Dr. Ramsamy.
Yeah. No, I think if you look at the duration of the headache and the associated symptoms, all point to a systemic, an infectious process getting localized in the central nervous system. That's what I would think. And there, of course, you worry about partially treated bacterial meningitis, about tuberculous meningitis. So I think if you can hear me.
Facing with a child with headache, when you're faced with a headache, what is the cutoff to call this a chronic headache or an acute headache? What is the time period? Would this child come under the category of acute or chronic headache?
Now, I think, I think 15 days in a month for about 3 months or so. That's what the literature says. But here, the situation is one of less than 15 days duration. And there are systemic manifestations here. It's not only the headache. The systemic manifestation of form of fever, put them together, I would still think of them an infectious process. And then I wouldn't be surprised if it is there in the central nervous system. And this is a situation where, unless there are compelling reasons for the imaging, I think a CSF analysis is far more important.
Thanks.
Sir, I agree. It's an acute infectious process. I think the foremost in our mind is to rule out acute bacterial meningitis and establish the etiology. Second is, this still falls under the acute category, sir. Everything has happened within 15 days. We would still put it as an acute headache only.
So acute or chronic headache is arbitrarily divided at 2 weeks, sir?
No, I think if my memory serves me that as well, it is 15 days in a month and then for about 3 months or so duration. That becomes a chronic headache.
Yes,
you can check on that. 15 days in the 30 days and then going on for about 3 months. That becomes a chronic. But more importantly, one must look at headache this way. You see, it is a recurrent headache with normal periods in between. That also is a chronic but recurrent headache, but chronic, persistent, progressive headache. And that's a completely different category. Persistent, progressive chronic headache is a different category. So I think, basically, the time interval you asked for, quoting from up to date 15 days in a month, and then more than 3 months, we call chronic. But I think that is not that important for a practicing pediatrician. What is really important is whether it's a persistent or progressive headache, regardless of the duration. Then you have some pathology going on.
Okay, thank you. Dr. Purnima, you can complete one.
Yes, sir. So on clinical examination, she was conscious, oriented with GCS of 15 by 15. Her pupils were normal size reacting to light. On both eye examination, she had a bilateral lateral rectus palsy, and power was 5/5 in all four limbs, with tone normal in all four limbs. Deep tendon reflexes were 2+ in all four limbs. Bilateral plantar was flexor. No signs of meningeal irritation. No mastoid tenderness, and spinal examination was normal. On investigations, her complete blood count, HB was 10.7 with total count of 22,900, neutrophils of 73 and lymphocyte of 25, platelet 4.5 lakhs, electrolytes were normal, and CSF analysis done was normal. We proceeded to do an MRI brain with MRI and MRV and spine screening.
Dr. Purnima, what were her otoscopic findings?
Correct.
Sir, it was normal, sir.
Okay. The proceedings.
Yes, sir. MRI brain with MRI and MRV and spine screening showed a subacute venous thrombosis in the right transverse and sigmoid sinus with signs of intracranial hypertension with bilateral automastoiditis. This is the MRI image showing thrombus in the right transverse sinus and right sigmoid sinus. On ophthalmological examination, there was bilateral papillary edema with bilateral lateral rectus paresis. On further evaluation for the cerebral sinus venous thrombosis, peripheral smear done showed normocytic normochromic anemia with neutrophilic leukocytosis. PT-APT INR done was normal. Prothrombotic workup done was normal. Sickling was negative. Serum fibrinogen was normal. D-dimer was normal. Fasting lipid profile was normal. SARS-CoV IgG and IgM antibodies were negative, and 2D echo was normal.
Dr. Pandian, sir.
Yes, sir.
Considering how common acute otitis media and the vagueness of the history Dr. Purnima has presented to us 15 days ago, history of fever, otalgia, which has been non-documented, how common is it for an uncomplicated AOM to present with sigmoid sinus thrombosis as a complication, sir?
Very, very uncommon, sir. We don't see otitis media presenting as cerebral venous thrombosis day to day, and because we see so many otitis media, and they produce mostly an acute meningitis like picture before they go in for complications, and especially they are justified because this is one case where there is a CT negative headache, and they are justified in doing an MRI, and in those cases I think we have seen venous thrombosis as a presenting as a cause for headache, but very uncommon. Professor Ramasamy, sir, you have your experience?
Yeah, I think once the CSF is normal, then you start thinking about other pathologies inside the cranium. But here, I must mention acute otitis media. I agree, Dr. Aswath. Acute otitis media, at the most, you may have some of them having an effusion, lasting for about a couple of weeks or even 4 weeks or 6 weeks. Otitis media resolving, otitis with the effusion. Beyond that, neglected otitis media not attended to, they may produce mastoiditis. Nowadays we don't see that in urban area. Everybody in an otoscope, everybody makes an early diagnosis. But earlier days, suppurative otitis media often result in mastoiditis. So suppurative mastoiditis and their abscess nearby were not uncommon. But this venous thrombosis, I normally associate venous thrombosis in dehydrated states in babies. Babies who are dehydrated, hypernatremic, jittery, convulsions. That's the kind of situation where you run into the cerebral venous thrombosis. I mean, assuming there is no primary hematological disorder. If primary hematological disorder, then I would think more in terms of dehydrated states giving rise to venous thrombosis. So this is indeed a surprise. Having mentioned this, I must also point out, it's not all that rare to have tuberculous mastoiditis. You do run into tuberculous mastoiditis. So pyogenic processes, tuberculous processes must be thought about. I'm glad the CSF was normal in this child because I was anticipating some kind of abnormality, in CSF. Especially tuberculous meningitis can fool us, with this kind of symptoms. But I'm glad CSF was normal. That's okay. Then MRI gave the diagnosis.
So, Dr. Purnima, do you think this child had an underlying tendency to thrombosis? Was it a prothrombotic condition unmasked by a very, very trivial AOM? Because the history that you presented is not convincing for an AOM of the suppurative or the purulent discharge or even a chronic or a recurrent AOM history. I'm quite surprised that a child with such a brief and uncomplicated AOM should want to develop a dreadful complication such as this. Was a prothrombotic work done up for this child?
Yes, sir. Prothrombotic workup was done and it was normal, sir.
Okay. Thank you. Can you just wrap up the case for us? What did you treat her with? What was the outcome?
Yes, sir. It was cerebral sinus venous thrombosis on the right transverse and sigmoid sinus. We started on enoxaparin subcutaneously at 2 mg per kg per dose BD and oral astazolamide. So dose adjustments of enoxaparin was done on regular monitoring with anti-factor 10A levels, and patch exercises were done for both the eyes alternatively, and the child is on follow-up. We are on follow-up with the child, and the dose of enoxaparin was altered according to the anti-factor 10A levels. The last anti-factor 10A level was 1.4, and currently the child is on enoxaparin of 20 mg and 15 mg. On ophthalmological review, there was a resolving papilledema, so the dose of astazolamide was reduced, and repeat MRI brain with MRI and MRV showed a resolving thrombus.
Can I interrupt you?
Yes, sir.
Enoxaparin now for how many days?
Sir, child is on enoxaparin for almost 1.5 months now, sir.
So is there a possibility that you could have changed over to oral anticoagulants?
Yes, sir. And the next visit, we are planning to change her to oral rivaroxaban, sir.
Yeah. Fine. Because yes, sir.
Dr. Purnima, I'd like to ask you. You said about 4 years the child's age. You said 4 years. Am
Yes,
I right?
sir. Yes, 4 year, 8 month old. Yes, sir.
Oh, so was he able to tell these complaints, articulate it very well, or was it the mother's interpretation of her behavior? Did this child come and really tell you that my head is hurting and this is how I feel, or did the mother interpret the manifestation as headache? Because the pre-verbal, before the age of 6 or 5, their ability to articulate is somewhat limited. I just want to make sure whether she articulated well.
Actually, it was basically the mother's complaint, sir, more than.
Okay. So there again, before the age of 6, headache is very uncommon, and especially before the age of 5 or 4. So here it is the mothers who interpret the behavior or alteration manifestations. So as a matter of fact, headache by definition, I'm sure Pandian would agree, it is a pain above the orbitomeatal line. Pain above the orbital meatal line is really the definition for a headache. Anything else is really not really part of the headache. So I'm glad the mother who interpreted this. Okay, thank you.
Sir, but children nowadays come out with symptoms of headache, and if they say consistently to one side, then we will have to give credence to their complaints, sir.
Okay, wonderful.
Thank you, Dr. Purnima and Dr. Janani ma'am, for the very interesting case presentation.
Thank you, sir.
We'll wrap up this case.
Thank you.
Thank you.
Thanks, Pandian sir.
Janani madam, nice case. Thank you.
Yeah, thank you. We don't know what's the reason because etiology still. Yeah.
Yes, I think both the cases we don't know the reason, and both the cases were benign. They presented with a false localizing sign. I think headaches are tricky nowadays.
Thank you, sir.
Can we have the next presenter, please?
Yes, sir. Can I present now, sir?
Dr. Patsati?
Yes, sir. Can you hear me, sir?
Yeah, we do.
Yes, sir.
Purnima, stop sharing.
Dr.
Purnima, stop sharing.
Stop screen sharing. Yes, Dr. Patsati, you can start.
You can go for a full screen mode. Yeah.
Yes, sir. Sir, can you see everyone? Can you see, sir?
Yeah, you can proceed.
Sir, good evening, everybody. I'm Dr. Parthasarthi from the GKNM hospital. And this is a case seen by senior pediatrician Dr. Angelina madam few years ago, and I'm presenting on behalf of her. Madam couldn't join us tonight. And this is a 15-year-old girl who presented to her OPD with complaints of headache for almost 1 week. It was a bifrontal throbbing type of headache lasting for a few minutes and sometimes up to hours. It was more during the daytime and in the awake hours. There was no history of any vomiting or visual disturbances, no history of any photophobia or phonophobia. There was no history of abdominal pain, fever, loose stools, no history of trauma, and there was no any history of recent travel. And regarding her past history, it was very uneventful. She was a second-born child to a non-consanguineous parents. There was no history of any migraine in the family members. Her antenatal and neonatal period were uneventful. Development-wise, she is while studying in class 10. Her academic performance has been on the decline recently at the time of presentation. She is an immunized child on a mixed diet. And regarding her clinical futures, on examination, she was conscious oriented. At the time of presentation, her vitals were stable. Her anthropometry weight and height were within 50th to 75th percentile. On examination of central nervous system, her higher mental functions, cranial nerves, motor, sensory, or cerebellar functions were normal. Her gait was normal. There were no any involuntary movements. Her spine and cranium were normal. Her other system examinations were also normal limits. And since she was complaining of persistent headache, they went initially she was treated with NSA with paracetamol. And since she was complaining repeated headache, initial investigations were done. Showed HB showed 11.3, and total counts platelets were normal. Her TFT organ functions were also normal. She has been referred to a neurologist, seen by a neurologist, and we also suspected nothing at that time. And since he was persistently complaining headache, on the second week they went ahead with an MRI brain to look for anything significant, and it showed no significant abnormality per se.
Dr.
And yes, sir.
We'll take
Yes,
a break.
sir. Yes,
MR,
sir.
sir. Dr.
An
MR, sir.
adolescent girl, adolescent girl, subjectively there is a lot of headache, but objectively hardly any finding. There is a discrepancy there.
Yes, sir.
Blood pressure?
And the blood pressure, did you mention blood pressure? Was the blood pressure
Yes, sir, it
check
was
normal?
within, yes, sir, it was 96 or 62 on the tree.
So,
it was normal.
You see, in a situation like this, as a general pediatrician, where you have the subjective complaints going on for almost 2 weeks, disrupting the routine, at the same time, a careful, comprehensive physical exam showing normal findings systemically as well as neurologically, including normal blood pressure, then you have to think in the primary type of headache, namely migraine and a muscle tension type. Now, those are the two considerations. You did mention some negative findings about, for migraine. But you said the nature of the headache, bilaterality, throbbing nature suggested, migraine. But at the same time, you didn't have sensitivity to light or, let us say sound.
Photophobia or
like
phonophobia.
So, yes. So I think, this is what I would think. And then I would, and especially, the MRI brain, this question arises when a neurological, systemic examination, you are completely normal. You are a good clinician, you are examined thoroughly, you haven't found anything abnormality, you have done that repeatedly. Should you still do an MRI? The literature says that the parents are very anxious and they want it, get it done. Otherwise, actually, imaging can really wait. Okay?
Agreed, sir. Agreed.
So I would think, Dr. Aswat, put it in a nutshell, I would still think in terms of primary headache, the migrainous type muscle tension. Probably I'll swing the pendulum towards muscle tension.
Thank you, sir. Pandian, sir?
Sir, but it's still in the acute stage, sir. She's only, the whole duration is only 15 days. Is it a daily headache?
History that a pediatrician should ask to say this is a muscle tension headache versus a psychological headache versus a premenstrual syndrome versus some school pressure or even manifesting as a manifestation of a deep-rooted psychiatric malady like sleep deprivation or depression. Are all these considerations in an adolescent girl? I mean, what are the points?
I think you're right. You're right. You have to consider all this. You have to consider.
So what are the characteristics of a tension headache which are differentiated from a migraine headache, sir, considering that investigations have a very limited role?
Yeah, the muscle, my limited experience with muscle tension headache is these are healthy children, and the headache is more of a compression or a pressure type, and it's usually the frontal area and bilateral, and usually in the evening hours when they are stressed, when they are tired, and they have to do some discomfort in the neck muscle area. So all these things put together, I would call it a muscle tension. Actually, it doesn't interfere that much with an activity, and they're able to bear the pain also. It's not something unbearable. They're able to bear the pain, they're able to move around, they're able to do their activity, even though some limitation is there. But this is how I look at the muscle tension headache.
And sir, quickly, what is the role of doing laboratory tests in a child with headache as the primary complaint without any other red flags on history or on physical examination? Should we go ahead and do things like CBC, vitamin D, sugar, creatinine, LFT, RFT? Is there a role for blood tests in headache at all?
Oh, no, blood test in a headache. I don't know. Please, Dr. Mandian, please respond.
Sir, I don't think unless you are dealing with the sickle cell anemia and you got a thrombosis headache, I don't think routine blood tests are going to throw any light for a headache. Second is a child with no localizing signs and where you are sure we are dealing with a tension type headache or for that matter even a primary headache. Just as Ramsamy sir said, even imaging is not necessary unless the parents are very much concerned. Of course, if you want to rule out a giant cell arthritis or any such associated collagen disorders, then you can go and ask for blood investigations.
So in a case scenario like this, when you are going to consider a neuroimaging for reassurance purposes, we all recognize that there is a relatively CT scans are cheaper, but there is a risk of radiation versus MRI, the cost, but it is more precision in its details. Definitely MRI is superior. So when we are going to do it for more of reassurance purposes, should we still go ahead with an MRI? If you're going to do an MRI, should we do an MRI plane or a contrast, or will a screening CT be reassuring enough?
Sir, MRI is a choice, sir, because we have a look into the posterior fossa tumors better than in CT. Two, we just saw in the second case a CT negative MRI, and even a routine MRI can be negative, but still the patient can have venous thrombosis like that. So I think when you are evaluating a headache, MRI is the preferred choice because we can have a look at the posterior fossa better, and we can have, just like they said, the optic sheets are better seen in MRI imaging than in CT. And third, you can always have a MR venogram, which will be more helpful than a plain MRI and even MRI with contrast. But I have seen we can pick up lesions in a CT if it is done with a high resolution CT and with a technologically competent person.
Okay, sir. So if I understand you rightly, if you're going to do neuroimage, it is better to go for an MRI with contrast rather than waste time with
MRV. With MRV, always. If you are evaluating a headache, MRV is should be definitely in the protocol.
So if you're dealing with a condition like an AV malformation or something else, an aneurysm, will an MRV pick it up or an MRA and MRV be needed, sir?
As you said, a contrast itself will pick it up, sir, and preferably if you suspect a venous malformation, MRA will be better.
Fine. Thank you so much.
So the criteria for migraine change now. To my knowledge, we had 7 criteria according to American Migraine Association, of which 4 have to be satisfied. Those were simple.
Okay.
Are they changed now? That you had to have headache, unilateral or bilateral, family history, vomit, relieved by sleep, so abdomen pain, those things, are they changed now?
Basically, the practical criteria still holds, sir.
Okay.
Right.
So in this case scenario, will migraine be a consideration, sir, considering the non-specific nature of the headache, the bilaterally, except the throbbing?
Sir, 15 days, the whole scenario is only 15 days. Migraine is said to be a recurrent chronic headache. But in this, the characteristics are throbbing headache and without any localizing sign. We still think of a primary headache, either it is migraine or a tension type of headache. So I would prefer more of a tension type of headache, especially an adolescent girl with a very, very short duration of 15 days. I would still think it's a tension headache in a chained priority. Second, I will think of a vascular headache, probably migraine.
Thank you, sir. Dr. Patsati, can you proceed?
Yes, sir. Yes, sir. As I said, the migraine and tension type of headache were the initial considerations. And on probing the history properly, it was found that she's having some psychological issues at school. Where she was on a boarding school, and she's been going through some disturbed sleep and increased screen time. And it was diagnosed to be a tension type headache, and which was managed with counseling and stress management with occasional NSAIDs. And on this occasion, we would like to bring into consideration that on the recently the screen time has been an upcoming issue in children, especially in adolescents with headache. So recent studies are showing that the association between headache and screen time is increasing, and the exact causality is not properly documented. And recent studies also indicating that the persons who already have a tension type of headache or migraine, they are having more episodes with increased screen time. So the study on electronic screen exposure and headache gave recommendations like there should be restriction on electronic screen usage by children, and the parents should make boundaries on how they should be used. If the boundaries are crossed, what should be done? What are the punishment consequences? And since it is an era of online classes, there has been some suggestions like the online classes should be limited to 2 hours per day. And if there is any continuous media usage, at least a 20-second break for each 20 minutes. These are some of the recommendations done given recently.
Thank you.
Yes, sir. Thank you.
Thank you, Dr. Patsati, for highlighting the importance of something which we all cannot live without, but at the same time, some sort of reining in has to be done on the screen time. So, point is well taken, and I think you have done a great job of highlighting the importance. Yes, sir.
Ashwat, one easy way of tackling I have found is 9 p.m. to 9 a.m. No blue lights. Screen, whether it is iPad or TV or cell phones. 9 p.m. to 9 a.m. I advise for all adults and children together. That probably they adhere to that protocol better than saying you have to look only for 2 hours or 3 hours.
Fine. That's something which we can try and practice.
Yes, sir.
Thank you. Thank you so much. Thanks, Dr. Patsati, for that very interesting presentation. Thank you. Can we have the next presenter?
Nidhi Alagan. Nidhi Alagan.
Hi, yes, sir.
I present the case.
Even answer for the
later. Your comes there. Seeing the Zoom.
If you have technical issues, we can ask somebody else to present. Dr. Nidhi Alagan, who can do next. Can you ask your colleague, Dr. Janaranjani, or we can ask Dr. Sangeet from Tirunelveli to present?
Sir, due to technical issue, we'll present next, sir.
Okay, ma'am. Is your colleague ready to present? Dr. Janaranjani?
Hello, sir.
Sasi on the top end. Okay.
Yes.
Dr.
She's online.
Can start. Dr. Sashi, are you ready?
Yeah, Sasi, you can go for full screen, please. Yeah, please proceed. Yeah, proceed. Sasi, you can present. Sasi Anand, you can present.
Thank you, sir. Good evening, dear friends and seniors. I thank IAPTNSC's team, and I thank especially Dr. Ashwat sir for giving me this opportunity to present a small case in this forum, and Dr. Sasian from Ramalingam Hospital, Salem. I present a case which we encountered last year. An 8-year-old boy presented with a headache associated with vomiting for past 2 days, and there is reduced urine output for past 2 days and swelling around the eyes for past 1 day. In the history of presenting illness, there was headache was there for past 2 days, acute onset, no aggravating or relieving factors. There was a constant pain in the occipital region associated with multiple episodes of vomiting, not blood stained. And there was reduced urine output for past 2 days. Like an history, he's passing urine once in 8 to 10 hours, very small quantities. There was no dysuria or no blood in urine. The swelling was around the eyes, which is gradually decreasing in size for past 1 day. There is no other significant history, no history of seizures, trauma, loose tools, or visual impairment, or abdomen pain or weakness of limbs, no history of vertigo, no history of exposure to toxins or native medications, recent vaccinations, dog bite, no history of flight travel recently, and his performance in school is good, and no other significant disease. Weight is 22 kgs and height is 125 centimeter, both between 25 to 50th percentile. On clinical features, like on examination, child was extremely irritable. He was constantly shouting, there is a, like, I'm having headache. And there was mild periodontal puffiness. Child was looking pale, and there was sweating pedal edema. And there was whole heel ulcer noted in right knee. And abdominal examination, there was ascites, no organomegaly, and no fibrosis. Other systems were normal. His gait is normal, and other neurological examinations, nothing significant. Since the headache was the primary complaint, we checked the BP. It was around 140 to 80 in the right arm, which is checked manually, which is definitely more than 99% for this age. And heart rate was 120 per minute, and pupils were equal and reactive.
Dr. Sashi, thanks. Can we take a break here? Dr.
Yes,
M. Ramasamy, sir.
This is fairly typical, the post-streptococcal glomerulonephritis, acute nephritis with hypertension. This is fairly typical hypertensive encephalopathy, and the child already complaining of headache. Indeed, this is, I would consider an emergency because it could progress very rapidly to seizures. And seizures, sometimes we find it very difficult to control, especially with hypertensive encephalopathy. So indeed, in my practice, I used to, especially with this type of presentation, I would check the blood pressure elevated. Even before sending to the hospital, I would give an antihypertensive. Those days we used to give, surpass, but now the diuretic, furosemide, I would give it as an emergency just to prevent further rise and then send them over. So this is a fairly typical situation. I don't think anything else we need to worry because healthy child, short duration, and fluid overload, elevated blood pressure, oliguria. Yeah. Hello?
But can hypertension itself cause an acute kidney injury as a hypertensive urgency?
No, hypertension per se causing kidney injury, basically it is cardiac output into peripheral vascular resistance. So unless it's a long-standing hypertension, I don't think a hypertension will say produce kidney injury. I don't see, even though I'm not a nephrologist. Basically, it is the cardiac output into PVR. So here you have a hypervolemia, and that's what's adding to it. And there is an oliguria. So they have not mentioned our creatinine, but your nitrogen, but I'm sure this is fairly typical one. And indeed, I would also look for a congestive heart failure, gallop rhythm, tachycardia. Other consequence hypervolemia is congestive heart failure. So both can occur, go to that. And this is a situation where once conversion occurs, you'll find it very difficult to stop it unless you bring down the blood pressure. Again, don't bring it down to, very well, only bring it to 2/3, bring it by 1/3 or so. Not really bring it down up.
Dr. Pandian, what is the mechanism of headache with sudden increase in blood pressure? And in the setting of an acute increase in BP, can all headaches be taken as evidence of posterior reversible encephalopathy syndrome, or should we confirm it with the neurological studies, sir?
all of them don't develop posterior reversible encephalopathy syndrome. I think we see so many patients with hypertension, especially adults. I see with BP shooting up to 200 to 180. Still, they go around comfortably. So all of them don't develop the posterior reversible encephalopathy syndrome. See, probably this relates to the rapidity with which the hypertension develops. So rather than the slow onset BP rise, here we have a situation where there is an acute kidney injury followed by hypertension. Over a period of 2 days or 3 days, the whole thing is evolved. Such patients develop a headache more than any other hypertension.
What is the mechanism of headache when there is a sudden increase in the blood pressure, sir?
So, see, the Ashwath, if you recall, the headache per se is due to stretching of the vessels, stretching of the structures around the brain. Basically, that's what. Basically, the brain per se is, there is no sensation, but all the vessels passing through, even some cranial nerves passing through,
trigeminal,
and
sir.
all your dura, all the structures around the brain, they are all, sensitive to stretch, and the stretch will very well produce, hypertension, headache, intense headache. Basically, that's what I think.
Yes, sir.
It's up to
the other mechanisms take a little time, sir. See, all the other mechanisms, alteration of the chemoreceptors, everything will take a little time. So the primary presentation, probably, I will agree that it is due to a vascular stretch.
Pandian, sir.
Yes, sir.
If we have a situation of a raised intracranial pressure, we understand that the blood pressure will be elevated in order to keep the cerebral perfusion going. So how do we say whether the headache and hypertension, which came first? Is it the high BP which is causing the headache, or the increased intracranial pressure which is forcing the BP to rise to keep the cerebral perfusion pressure? Can we put the horse before the cart?
I feel the...
Yeah, I think you... Go
yes,
ahead,
sir.
Go
yes,
ahead,
sir.
Go ahead.
Sir, go ahead, sir.
No, basically, you do have a situation of ICT increase with hypertension, but there is a bradycardia. They are bradycardia. But here the situation is different. Here you have oliguria, puffiness, and then you have a blood pressure. You look at the sequence of events. This clearly tells you, a different turn of events. Whereas the increase in intracranial pressure increase, giving rise to hypertension, there will be bradycardia. And that will be a primary event. And the bradycardia will be a secondary event. But here, the headache is a secondary event to primary, hypervolemia. Basically, it's hypervolemia. That's it.
Sir, again, one more thing I want to stress is Cushing's triad is a very late phenomenon. It is not a early phenomenon. It occurs only during a time of coning, or it's very late phenomenon. So hypertension secondary to intracranial hypertension is very late phenomenon, bradycardia and everything.
Okay, point taken. Dr. Sashi, can you complete the presentation?
Yes, sir. So blood investigation suggests of anemia. Other investigations, electrolytes, calcium, everything was normal. Urea was 48 and creatinine was 0.9. And urine complete showed plenty of RBCs and pus cells, 8 to 10 cells. Ultrasound abdomen, mild ascites and bulky kidneys. The MRI brain revealed in T1 weighted image, there is hypointense lesions in the occipital, parieto-occipital region. The T2 weighted images, symmetrical, hyperintense lesions in both the cortical and subcortical parieto-occipital regions, which is shown in the RMR. And supporting evidence, serum complement C3 levels were low in this child. So we thought a differential diagnosis of acute glomerulonephritis presenting as Press syndrome. Other DDs were acute viral encephalitis, ADEM, cerebral sinovenous thrombosis, intracerebral hemorrhage, and other metabolic encephalopathies like MELAS.
Apart from the fact that the child has oliguria, acute pyoderma scars, and such a sudden increase in blood pressure, I think there were really no differential diagnosis. You presented very well, and a very clear-cut case has been made for acute glomerulonephritis, probably post-pyodermal. Thank you so much, Dr. Sashi.
Thank you, sir.
Treatment was,
treatment was
Dr.
underlying.
Ashwath, I'd like to make one point to all the practicing colleagues. If you see this type of scenario in the clinic or office, don't be too academic. Simply go ahead and give a shot of furosemide and then send them over, because it makes a tremendous difference.
Yes.
Because you give a shot furosemide and then it reduces hypervolemia, you prevent the child from going into really further down the line. So I think that is something I would like to stress.
Thank you, sir. Point taken. So the also importance of measuring simple vital parameters like blood pressure and heart rate in an acutely unwell child will go a long way in establishing the cause, whether there is headache or not. It's always a good thing to measure the vitals and record them in any acutely unwell child. Dr. Pandey?
And also use your ophthalmoscope.
Yes, sir, for a change.
Press, do you have this kind of tachycardia in press, sir? At Pandian, sir?
Tachycardia in press, sir?
What was the heart rate here? Was it
120, 120, is it?
Sir, it can happen, sir.
Yeah, see,
Yes,
I was mentioning about congesting, heart failure. You can have actually, I don't know, you can have a congestion, and then you can have some tachycardia there. We have had tachycardia, we haven't even galloped rhythm, we haven't even cardiomegaly, even a pulmonary edema. All this can occur. So this is one type of presentation. Another is, of course, congestion, pulmonary edema. And
Yes,
I think, any mention about chest X-ray, any chest X-ray there, I didn't see. Okay, fine.
Okay, we can wrap up this case meeting. Thank you, Dr. Sashi, for the very nice presentation of hypertensive urgency.
Thank you.
Is Dr. Neranjan? Thank you, Dr.
Sashi. I thank Ashwath, sir, and it's very really nice to see MR, sir. I saw him 9 years back at Masonic Medical Center when I worked there. It's very nice and honor to see MR, sir. And same enthusiasm you are showing even after 10 years. Before 10 years, you show the same enthusiasm. Now, same.
It's all because of Dr. Ashwath and Dr. Rajendra.
He is bound by love to us.
Really wonderful, sir. Thank you, sir.
Thank you, Dr. Sashi. Is Dr. Niranjan ready?
Nidhialagan.
Sanjeevida probably is ready.
Nidhialagan, are you ready?
Raju, sir, your PG is ready, sir?
Yes, sir.
Present the case.
Who do we see on screen now?
I'm fine, I think.
Dr. Raju, sir, if your PG is present, can she start?
Sanjeevida, are you ready? I think you can start if you're ready.
Yes, sir.
Dr. Sanjeev?
You can share your screen.
Yes, sir.
Okay.
Yes, ma'am.
Yes.
Good evening, everyone. I'm Dr. Sanjeevita, DMB resident from Krishna Maternity Home and Pediatric Center, Tirunelveli. Today we'll be seeing about a 3-year-old girl child who came with history of headache, fever and vomiting for the past 10 days and weakness of the right upper limb and lower limb for the past 7 days. Initially, the child was apparently normal 10 days back. Then she developed severe left-sided headache, which was intermittent and not responding to analgesics, which was later followed by fever, which was low grade, intermittent, not associated with any chills and rigor. She was active during the afebrile period. The child had history of vomiting for the past 10 days, at least 5 episodes per day, not relieved by antiemetics. 3 days later, after the onset of initial symptoms, the child had developed weakness of the right upper limb and lower limb, which was sudden in onset, which gradually progressed to the current state. There was no history of difficulty in vision, speech, swallowing, or walking. There was no history of trauma, fever, loss of consciousness, or seizure. There was no history suggestive of cardiac or hematological pathology. The birth history was normal. Developmental was she was normal. There was no significant family history. Coming to the clinical features, the positive examination findings were she had pallor, the vitals were stable. Coming to cranial nerve examination was normal. The motor system examination, the right upper limb and the lower limb, there was hypotonia and the power was only 1/5. The reflexes, when the superficial was 1+ and the deep was 2+. The sensory system was normal. There was no cerebral signs. There were no signs of meningeal irritation. The CVS system was normal. Then coming to the initial investigations, the CBC.
Sanjeev, can you just summarize the points that you've told so far, ma? Just a brief summary of the case progression till now.
A healthy 3-year-old child suddenly developed headache followed by fever and vomiting. 3 days after the onset of the initial symptoms, she developed weakness, unilateral weakness of right upper limb and lower limb, which gradually progressed to the current state.
Okay, thank you, ma'am. So, Emma, sir, this is the point.
No,
in
you
a
see,
child who is 3 years old,
yeah.
How often can we get a classical history of a left-sided headache? How often do we miss headache in pre-verbal children? Is there another way of knowing whether they are actually experiencing headache?
Yeah, this toddler actually presented with a stroke. There is no question. There is a weakness on one side. This is an acute stroke in a toddler with systemic manifestations preceding. So you need to think in terms of an infectious, ischemic, as well as thrombotic process inside the head. Now, whether this child would verbalize and tell the mother that my head hurts, that 3-year-old, it's the mother who interprets looking at the child. But looking at the the chronology, the sequential, the symptoms, the way the symptoms appeared, and then the weakness developed, I would consider this child to be an acute stroke. And moment you have an acute stroke in a child, obviously you'll focus on the blood as well as cardiovascular system, hematological and cardiovascular system. And then of course you will do imaging study. So this would be my basic approach to this child. And she mentioned about pallor, and I do not know whether it's severe pallor or mild pallor or moderate pallor. Because severe pallor, you can have sicklers. See, severe pallor, you can have spleen, sicklers can present with an acute stroke, and they can involve painful episodes. So of course, iron deficiency anemia is very common. They can also, present with a moderate to severe degree. So basically, I'm dealing with a child with an acute stroke with systemic manifestations. My approach would be straight away get an MRI. If ever possible, a CT, which of course expose the child to too much of radiation.
Pandian sir, what is
that's what I would think.
Approach to a child with the acute onset of a unilateral headache, sir?
That child has developed a lateralizing sign, just as Professor said. Child has developed a hemiplegia on one side, and so the localization shifts to the opposite side. Since it is acute, almost 10 days, I think either we are considering a vascular cause or an infectious cause. It could be since there is an anemia as well, we will have to look for any other vascular etiology in this child. So I would look for an imaging which may show either a thrombotic episode or an inflammatory lesion. So the lesion, most probably the whole thing is lateralizing to the left, and the lesion probably either it is a vascular or an infectious process.
How often is headache associated with a hemiparesis or a stroke, sir? Is headache a common presentation?
It's not a common presentation of either a vascular occlusion. Usually headache happens when there is a bleed. So if when there is a bleed, you have a headache followed by a stroke. But when there is a thrombosis, we don't get a headache as a primary manifestation. So that leaves it with the second possibility, whether we are dealing with an inflammatory lesion.
Fine. So basically, we are looking at a bleed or an infectious or an inflammatory pathology. the side of the weakness.
Yes,
Right.
sir.
Thanks. Thanks. Dr. Sanjeevita, you can proceed, ma'am.
The initial investigation, CBC showed low hemoglobin, which was in decreasing trend. The child has normocytic and normochromic anemia. The platelet was in the higher end of normal. The child had mild leukocytosis. The coagulation profile APTT PTINR were mildly prolonged, and the peripheral smear showed normocytic normochromic anemia. We did a CT brain, which showed left frontal lobe hypodensity with edema in the subcortical white matter with few linear hyperdensity. So we proceeded with the work. The workup for etiology. We did MRI and MRV, which include MRV. MRV showed left frontal lobe venous infarct with bleed, extensive superficial and possible deep venous thrombosis. The D dimer was high, and the CSF analysis was normal. We also did an EEG, which showed left hemispheric slowing with interictal discharges from the right hemisphere. This is the MRV report of the child, which showed complete thrombosis of the superior sagittal sinuses, confluence of the sinuses, and that bilateral transverse sinuses, straight sinus, vein of Galen, and internal cerebral veins.
So basically, she's having extensive thrombosis of the entire cerebral venous system. Is that right, ma'am?
Yes, sir.
And a previously healthy child with no apparent reason why she should undergo thrombosis, like a hypernatremic dehydration or sepsis or shock, or not a known sickler, not a known diabetic. So the only clue we have is a mildly prolonged PT-PTT and elevated D dimers. Is that right?
Yes, sir.
So did you work her up further, ma'am?
Yes, sir.
Yeah, please
We did
share.
a thrombotic workup. The echo is normal. The NA is positive. The thrombosis single nucleotide polymorphism panel assay done, which showed methylene tetrahydrofolate reductase and factor V gene mutation, but the homocysteine levels were normal. This is the report of the thrombosis SNP panel assay. The diagnosis is the right hemiparesis, a left frontal lobe infarct due to cerebral sinus venothrombosis, which is due to MTHFR gene and factor V gene mutation.
Dr. Pandian, sir, could you interpret that report? Can you go back to the previous slide, ma'am? Yeah, this one.
Sir, I am not comfortable, sir. I have not come across heterozygous mutation of factor V, sir.
Dr. Sanjeevita, can you explain to us what this panel means, please?
This is the single nucleotide peptide, a polymorphism, if it's present in the genes of clotting factors. The factor V laden was negative in this child, but the factor V, there was factor V mutation, which is heterozygous mutation, and there was which was combined with the MTHFR gene mutation, which was homozygous, causing thrombosis in this child.
So basically, the last but one,
I'd like to ask you,
770, that is the one which is causing the pathology, because the factor V heterozygous state, would that be associated with the prothrombotic state, ma'am?
Yes, sir.
So in one child, we have two etiologies for clotting.
Yes, sir.
Raju sir, can you clarify?
This is often reported like this. This is MTHFR gene mutation and factor V laden mutation. That's what is being reported by SNP panel assay. But I believe they are combined. I do not also have much experience. It's probably the second case which you are seeing in my lifetime.
So should the child go on a lifelong anticoagulation, sir?
I do not know. The child was being followed up for nearly 2 years. Initially, do you have the treatment details, Dr. Sanjeevita? This was initially given, and the child was given prophylactic anti-epileptic measures initially. Specific measures like enoxaparin 1.25 milligram per kg BD for 3 months, if I am correct. And then no antithrombotic measures were being followed up, and the child is being followed up for nearly 2 years since now, if I am correct. 1 year or 2 years, 1.5 years.
The child on any oral anticoagulant, sir?
No, it is not on any oral anticoagulants as of now.
Okay.
Any comments, Emma, sir?
Just recently, there is an article published in New England Journal of Medicine on acute stroke, and it categorizes that into thrombotic and bleeding. And of course, thrombotic, you have ischemia beyond that. But the authors make a very important point there. Extremely small percentage of children with the thrombosis in one of those arteries, especially middle cerebral artery, they can be helped if you can give the tissue, the plasminogen activator. Percentage where the child acute stroke, where if you can get them very soon into the imaging, area, if you can, especially the MRI, vascular studies, if you do, and make the diagnosis of a thrombosis in the middle cerebral artery, then immediately they can, inject this tissue plasminogen activator and relieve the child of thrombus, and the whole hemiparesis goes away. And this they point out, because there are so many other causes which neurologists are more familiar. And of course, the hypercoagulable state that has given rise to, I was expecting some kind of a, block in the middle cerebral artery area, especially the hemiparesis over there. But then they turned out to be, more of a generalized venous sign thrombosis, and then more of an infarct in the frontal area. And so I think perhaps I would suggest all PGs to go through that very beautiful review article on acute arterial stroke in children. Because that particular one turned into Moya disease, but they do vascularization, etc. But I think this is a very small percentage. Of course, this is a North American setup. Dr. Pandian, yes, you can comment on that.
Sir, we have wide experience with tenecteplase or atylase in adults when they land up to you with stroke. But in children, I think we have just started using it as an acute thrombolytic agent. Immediately, if they recognize a block.
Yeah.
So as you said, whenever you are asking for an MRI, you also ask for an MR angiogram, so that we are, or a CT angiogram, which will give you the location of the block. Here probably this child, the whole thing was triggered by an acute episode of vomiting or mild dehydration with a thrombotic tendency, went on to a venous thrombosis, and with that venous thrombosis gave rise to an infarct, which was, I think, probably infarct and a bleed. Probably that was the cause of the whole presentation.
Yes.
Fine.
Thank you very much. Thank you, Dr. Pandian, enlightening us. Thank you. Thank you, sir.
Thank you, Dr. Sanjeevita, for highlighting us on a very, very unusual cause for hemiparesis and headache, and also taking the extra effort to go to the molecular level of diagnosis and making sure that this child doesn't have a recurrence of these events. Thank you, ma'am. Thank you for sharing this interest.
Thank you, sir. Thank you, sir.
Dr. Balaji, is your PG comfortable to present now?
Yes, sir. They will do, sir. Jalanjani?
Yes, sir.
Start presenting, ma.
Sir, I'm getting only host can share, sir. I couldn't share my.
You've been made a co-host, Dr. Jalanjani.
Yeah, Dr. Thuru?
Yes.
Yeah.
Yes, sir. Actually, she has been made the co-host.
Yeah, you can do it now.
Sir, can you see my presentation, sir?
Yes.
Yes, sir. Can I start, sir?
Yes, ma'am.
I'm Dr. Jalanjani from Dharmapuri Medical College. I would like to thank our HOD and Balaji sir for giving me this opportunity, and all the eminent personalities here for giving us this wonderful teaching experience. So my case is an 8-year-old male child brought by his mother whose reliability is bad, with the chief complaints of headache since 4 months. The headache was insidious onset, intermittent in nature. It was more of a dull aching type of headache, frontal headache. It was not aggravated by light or sound. There was no aura. The child now complained that they had around 3 to 4 episodes per week. There was no associated complaints of fever, projectile vomiting, no cough, cold, seizures, no history of trauma, blurring of vision, or contact with TB. The examination was done, which revealed that the eye examination was normal. There was no sinus tenderness. There was no neck stiffness. BP was recorded, which was shown. Examination was done, which was normal. It was also done, which was told, which was not. The ophthal, since the child had such episodes, ophthal opinion was sought and there was no refractory error. ENT opinion was obtained, was no sinusitis. Neurologist opinion was obtained. There was no neurological cause for headache. Since the mother insisted, a CT brain was done, which also revealed to be normal. The child was given paracetamol. The child headache relieved with paracetamol and sleep, but still the mother gives complaints of repeated such episodes. So since we didn't have any associated features or a definitive cause, on provoking the history, the mother further revealed that the child had a history of increased screen time of around 6 hours, more than 6 hours, and mostly that was a late night prolonged phone usage. There was history of sleep disturbance, there was behavioral disturbance, there was school absence, there was decrease in scholastic performance, and there was an increase in adamancy and other behavioral complaints. So with all these history and with already known studies showing that screen time being a cause, we thought of tension headache due to an increased screen time. So along with the paracetamol for the episodes, the child was counseled for reduced screen time. Psychological counseling was sought. The child was encouraged to decrease the screen time. According to AAP schedule, the screen time has to be less than no screen time for children less than 18 months and only less than 2 hours of screen time with parental guidance in children less than 5 years. The child, it took nearly 2 months for us to reduce the screen time in regularizing the sleep cycle of the child. Nearly after 2 months, there was no such episodes of headache. The sleep cycles were regularized and the behavioral and stool regularization changes were also noted. And hence we concluded as that the headache due to the increased screen time. Not only this, due to increased screen time, we have also putting a paper based on the increased screen time effects on children, which varies from small children with speech delay to behavioral changes to sleep disturbances and even adolescents facing behavioral complaints. Here the presenting complaint was mainly headache. Thank you, sir.
Dr. Ramsamy, sir.
That's fairly typical. I think he has given the diagnosis. He also given an explanation. But again, as I've been mentioning, the headache, that is bearable, that recurs, and then, you have no positive finding in physical exam, you have no positive neurological examination, and then there is an environmental, triggers there. I think everything put together, I have to agree with her. This is probably that type of headache, tension type of headache. And so I think, she also mentioned why the brain imaging was done. And in my, of course, experience, indeed, even literature support is there. Refraction errors hardly ever produce headache. And so I think, sinusitis is, of course, a different ball game, except the frontal sinusitis. Other sinusitis are all, actually, as I mentioned, by definition, if you take definition orbitomiac line, these are all different conditions altogether. That's all I would say.
But in this case of excessive internet usage or excessive screen time, what exactly is the mechanism of headache, sir? Is this just sleep deprivation or is it resetting of?
I'm unable to give you a I'm unable to give you a straight answer. I think I have read the literature before I could tell you. This is probably, more psychogenic.
Maybe from Dharmaburi,
yes.
The phone usage which cause blue rays, which is cause problem with the brain. That's why it is cause more problem even when compared to TV. And even though in the olden days children are watching TV, those days this much problem is not present. But while using cell phone, this blue rays from the phone will cause more problem to the children, which affect the brain frontal lobe. And the less than around 2 to 3 years, we are having a lot of cases now with the speech delay, with autism like pictures. We are nowadays receiving a lot of cases, sir, actually. In the age group of 5 to 10 years, there is increased adamency, headache like these cases, and school skipping. These are the cases we are receiving. And in adolescent age group, the problem is different because of increased screen time. So their behavior is changing, and they are watching pornographic videos. And we had a very bad incident. 2 children at the age of 16 years brought with HIV positive by viewing just because of this phone only, sir. This much have a problem because of increased screen time, mainly after this COVID pandemic. So this is high time we have to educate the parents and attend parents also, because when we did the study, the main cause for children watching increased screen time is the parents also addicted to the phone. Majority of the time in homes, they are also addicted to the phone. That's why children are watching the phone, sir. So parents should be educated, and the counseling should be given both parents also. Otherwise, in future, this problem will emerge major in pediatric age groups, actually.
No, you are right. Even geriatric, my wife and I communicate across the room through the mobile phone only.
Balaji, sir, or comment?
Yeah, it has come to
Can
that
I make a
stage.
comment?
So you are right. You are absolutely
Yes,
right.
sir. Yes, sir.
Balaji sir, that's why I told you. This blue light avoidance between 9 p.m. to 9 a.m., I think that's a simple rule everybody can follow. That is one thing.
Yes,
Probably the second thing is the child has got an attention seeking, might have an attention seeking behavior.
Okay.
And third observation is, before this etiology of phone usage is brought out, I have hardly seen last 4 years any seizures triggered by excessive phone usage. That is one thing which is puzzling. Actually, we say the more electronic exposure they have, they are likely to activate a focus in the brain, and they are prone to seizures. The last 5 years, in spite of the internet usage and phone usage, I'm yet to see seizure triggered by the electronic in the gadgets. Probably cell phone and iPads are better than TV rays.
Thank you, sir.
Thank you. And Dr. Jananjani, it will be useful for you to go through this screening tool called the PRIOS tool, ma. This is basically problematic internet usage syndrome screening tool. So it's called the PRIOS tool. Probably you can peruse that, and also at a future time communicate to us what you learned and whether you could apply it as one of your postgraduate thesis topic to see how to formally make a quantification analysis and be objective about the time that is spent in front of the screen and the ill effects, whether there is a dosage effect between the time spent in front of the screen and the severity of the clinical illness. So that will be a very interesting thesis topic for postgraduates. So you can look at the PRIOS tool, problematic internet usage syndrome screening tool. It's called the PRIOS tool. So you could give thought to that. Very elegantly presented. Thank you so much, ma'am.
Thank you, sir. Thank you so much for the opportunity, sir.
Thank you, sir. Thank you very much, sir.
Thank you, Dr. Balaji, for mentoring your graduates. Dr. Priyanka Sohani.
Yes,
Dr.
sir.
Priyanka, are you ready with your case presentation, ma'am?
Yes, sir. Yes, sir.
Yeah.
Shall I share the screen?
Yes, ma'am.
Just a moment, sir.
This is the last case, no? That's
There's one more case, Talewa, from Dr. Balaji's group. How are the technical difficulties on the Dr. Nedunjay?
Jananjani will share the slides of Nidhalagan, sir, from next case, sir.
I'll share next the slides, sir.
That means we can proceed, Dr. Jananjani. Yeah, start.
Nidhalagan?
Yes, sir. I'm ready to present the case, sir.
Yeah, start. Yeah,
Shall I start, sir?
Yeah, please.
Nidhi, audible and visible. Go through.
Yeah.
Go ahead.
Yes, sir. Sir, I'm going to present. I'm Dr. Nidiyalagan from Dharmaburi Medical College. I'm going to present a case of interesting case of headache. Say, case of 8 years old female child was brought by her mother, whose relative is fair, with complaint of headache since 1 month duration and complaint of 2 episodes of seizures 7 days back. On history of presenting illness, the complaint of headache for the past 1 month, which is incidence onset, intermittent nature, throbbing type of headache, which is associated with vomiting. Complaint of seizures in the form of focal seizures involving the twitching of mouth on right side, 2 episodes 7 days back. First episode lasting of less than 5 minutes and second episode lasting for 15 minutes. There is no history of loss of consciousness associated with seizures. There is no history of fever, no history of cough and cold, no history of trauma, no history of blood vision. There is history of intake of raw vegetables frequently and no history of contact with TB. On examination, child was conscious, oriented, afebrile, no neck stiffness, no sinus tenderness, BP was normal. On all system examination done was normal. BC scar is seen in the left deltoid region. Fundus examination was done, which was found to be normal. On investigation,
no.
See,
no, before investigation. Okay, yeah. Already you are showing the results now. Before,
Image.
I think, yeah.
Yes.
Yes, sir.
Yeah, I think, Dr. Aswat, yeah, this child, yeah, headache and seizures, it clearly tell you there's a cortical pathology. It's as simple as that. So there's a cortical pathology. Whether cortical pathology was about to show the, imaging, and so it could be a tuberculoma, it could be cysticercosis, it could be, anything. So all we can say is there is definitely a cortical, injury pathology there that could explain both these symptoms. And especially if it were to occur, I mean, there is a typical seizure. I don't think they complain of headache, but the early morning hours during sleep, they wet the pillow, there's salivation, there's a twitching there. They may remember, they may not remember, and so-called the Sylvian epilepsy. And I was thinking about that when he was mentioning about those, when he was describing the focal seizures. But I think, headache is not part of it.
Sylvian
so
seizures.
headache and this only cortical pathology. Yeah.
Yes.
Okay.
Basically, what Professor Sir is saying is if you have a headache with a focal seizure, there should be very, very low threshold for neuroimaging because therein lies the clue to the etiology. Dr. Pandey, you want to add
Yes, sir. I think we'll have to go and roll out a cortical pathology, which will explain both the headache as well as the focal seizures. Whenever you have a focal neurological sign, I think that's an indication for a neuroimaging, preferably an MRI with contrast.
Sure.
Dr. Nidiyalagan, what was the location of the headache? What was the location of the headache?
See, the location of the headache, I mean, in terms of location, the location of pathology, as a non-neurologist, we have seen what's known as Jacksonian march, where the focal motor seizure commences in the thumb and the fingers, moves proximally to forearm, upper arm, shoulder, and child maintaining posture and also consciousness. You can very well say it is in the motor area.
Okay.
The motor area of the cerebral cortex. When you have that Jacksonian type of epilepsy, like that, depending upon the type of epilepsy, you can try to say whether it is in the, frontal area or temporal area or a parietal area or occipital area. It is possible to localize. It is possible to localize. It depends upon, the associated manifestation, which I just mentioned one, Jacksonian march.
Yes.
Okay, sir.
Hey, doctor.
Yes, sir.
They come under the, as Sir said, they come under the category of aware. The patient is aware. They are called partial seizures, and he can be aware of the seizure. So, and usually it's a motor phenomena. Only when it spreads, you have a Jacksonian march. Say they can have a simple right focal seizures.
Yes,
patient can be totally aware, and this goes under the classification of aware, partial seizure or seizures with a total preservation of awareness.
Awareness. Good.
Can we have the images, sir?
On proceeding with the investigation, complete blood count was which was found to be normal. Man 2 was negative. Chest X-ray was done, which was found to be normal. RGJ for CBNet was negative. A CT scan of CT brain was done. Plain CT showed edema was seen in the left parietal region. On CT brain contrast, there is single ring enhanced lesion with perilesional edema noted in the left parietal region, which is suggestive of vesicular type of neurocysticercosis. Ocular examination done and ruled out ocular cysticercosis. The differential diagnosis include the neurocysticercosis tuberculoma. The onset of illness will be in the differences between the both will be onset will be acute in case of neurocysticercosis and subacute in case of tuberculoma. Features there will be seizures first in case of neurocysticercosis, fever followed by failure to gain weight. Seizures will be seen in tuberculoma. Focal neurological deficits will be rare in case of neurocysticercosis, which will be more common in tuberculoma. ICT features are commonly seen in tuberculoma and systemic disease are seen in tuberculoma. On imaging CT brain, the lesion will be of less than 20 millimeter size in case of neurocysticercosis and more than 20 millimeter in tuberculoma. The number of lesions will be multiple in case of neurocysticercosis. The margins are thin and regular in neurocysticercosis, which will be thick and irregular in case of tuberculoma. Perineal edema will be minimal in case of neurocysticercosis and more in tuberculoma. Midline shift will not be present in neurocysticercosis and may be present in tuberculoma. The site of lesion will be more usually gray and white matter junction in case of neurocysticercosis. Based on the clinical features and the imaging study, the diagnosis of neurocysticercosis was made in this child. The child was treated with prednisolone 1 mg per kg for 1 week, which is for edema, and the tablet albendazole 15 mg per kg per day in 2 days was started. After 2 days of starting steroids were given for 14 days. Anticonvulsants in the dose of 10 mg per carbamazepine 10 mg per kg was given per day. All members of the child was treated with albendazole. We are planning to repeat CT brain after 1 month of duration.
Thank you, Doctor. Dr. Pandyan, what is the recommendation regarding repeat imaging, sir? If the diagnosis is cysticercosis and we don't anticipate any resistance to albendazole, steroids, and anticonvulsant, what is the role for repeat imaging? Should it be done after 1 month or 3 months or even after 1 year? And what is the rationale for doing a repeat imaging, sir? Pandyan, sir?
Am I audible? Am I audible?
Yes, sir. Yes.
Right. If there are no focal deficit, no seizures, no headache, child is doing well after a proper course of albendazole and anticonvulsants, I think you can wait for 8 weeks to 12 weeks for a repeat CT. And if the CT shows resolution, you repeat a CT after 1 year.
So what is the minimum duration of anticonvulsant therapy in such a child, sir? Even if the cysticercosis is disappeared, if follow-up CT shows complete resolution of the single ring enhancing lesion, can we stop the anticonvulsant safely or should it be extended for a longer period of time?
1 year, sir. Standard
Minimum.
protocol is 1 year. And if the lesion shows a calcification and if there is an epileptic activity, you decide on continuing the dose.
Okay, sir.
At 6 months, if you are convinced,
postpone the CT and continue the anticonvulsant for a minimum period of 1 year.
1 year.
And decide on the need for AED based on CT findings and the risk for recurrence of seizures.
Yes.
Do I read you rightly, sir?
That's right, sir.
Fine. Thank you. We come to the last patient.
This case was reported as tuberculoma by the radiologist, but as the clinical features and other features we are comparing obviously show suggestive of NCC, and again neurocysticercosis is more common when compared to tuberculoma. That's the main thing we want to stress here. So majority of many people will give both the ATT and albendazole. It's not necessary. By clinical features and CT will give clear-cut diagnosis that whether we are dealing with a case of NCC or tuberculoma. In these situations, steroids and albendazole alone enough to treat the child.
Thank you, Dr. Balaji, sir. Dr. Priyanka Sohani, are you ready to share screen scan, ma? You're on
Yes, thank you, sir. Thank you very much, sir.
It's been almost 2 hours now. We'll have the last presentation from
Shall I
Dr.
share it now, sir?
Yes, ma, please.
Sir, is it visible?
Yes, ma'am. Yes, please go ahead.
Okay. Good evening, sir. So I'll be presenting a case of acute febrile illness with headache. The case history is like 10-year, 4-month-old school-going boy presented with complaints of headaches in 7 days, complaints of vomitings in 7 days, and history of fever for initial 2 days of the 7 days duration. History of presenting illness, history of headaches in 7 days, which was localized to frontal and occipital region, moderate severity and episodic and dull aching type. No history of associated dizziness, light sensitivity, aura, abnormal movements, altered sensorium, or recent trauma. There is history of vomitings in 7 days, which was non-projectile, non-bilious, about 2 to 3 episodes per day, and there is no diurnal variation and not associated with food intake. No history of associated abdomen pain, altered bowel habits, or urinary symptoms. There is history of fever for initial 2 days of illness, which was high grade, intermittent, not associated with chills or rigors. And apart from that, the child also had post-nasal drip, non-productive cough, and poor oral intake. Birth history was normal. Past history, there is history of recurrent headache in the past. Family history, there's no history of similar complaints in the family, and the child is born to non-consanguineous parents. Developmental history was found to be normal. He was immunized up to date as per IAP schedule. On examination, child looked well nourished, alert, and afebrile. His vitals were normal. BP was 100/70. And there was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. No rashes were noted. Pulse was good, and tongue, tonsils, and throat were normal. Anthropometry was found to be normal. On systemic examination, CBS was normal. RS, paranasal sinus tenderness, was not there. No nasal polyp. Ears were normal, and there were no added sounds. On per abdomen examination, there was no palpable mass or organomegaly and no bruise. CNS examination, no signs of meningeal irritation, and it was within normal limits with no cutaneous markers. And fundus examination was found to be normal. So at the end of examination, we came to a provisional diagnosis of acute febrile illness of non-cephalic origin, most probably viral, could be secondary to flu, dengue, or any non-specific viral. And second differential being acute exacerbation of primary headache disorder in view of his past history. So we did the relevant investigation with basic fever workup, and the fever workup panel was found to be negative.
Dr. Priyanka, you can take a break here.
Yes, sir.
Professor Ramsamy, sir.
Yeah, I think, here everything would depend upon how the child appeared, at the time of, arrival and then an examination. The child really looked well and afebrile, that absolutely normal findings. Then I wouldn't give that much of weightage to the fever, because the fever, the first 2 days, it's worrying. But then the fever lasted only for a day or two, settle down. So in that kind of scenario, I'm not really that much worried about ongoing CNS infection. Extremely unlikely. Extremely unlikely. So I think an infectious process outside the nervous system, probably a very short-lived. I think I would agree with their formulation. The next question is like headache and vomiting. Even though when you listen to them and the duration kind of worry you, but then what is important is reassuring normal physical exam, normal neurological examination. I'm not really that much worried about so-called headache and vomiting. So I would agree with their approach.
What are the causes for recurrent headache that is one is likely to see in practice, sir? In OP practice, what are the causes for recurrent headache with apparent normalcy between the headaches?
No, here the recurrent headache. See, kind of difficult to give you one straight sentence and answer. See, this kind of a headache recurrent. The commonest I would see in our hospital, about 60,000 children seen over a period of 30,000 children seen over a period of 3 months. We had only 120 children with a primary diagnosed headache, and then in that, the commonest reason for that, primary headache, the clinical impression, is a systemic infectious process, usually virus, occasionally bacterial. That's the commonest. Now, children do contract infections every now and then. So I would presume, the commonest cause for a very benign, recurrent headache would be a systemic infectious process. So in other words, this secondary type. But of course, the primary type, the migraine and the tension type of headache. But the commonest we run into in our day-to-day practice is systemic infections with some kind of headache associated with that. Otherwise, they are normal.
Dr. Pandian, how do we differentiate migraine headache from cluster headache from tension headache? Are there any useful clinical pointers, sir, that we can look at? How common are cluster headaches and other headaches of recurrent nature?
See, tension headaches and migraine headaches, I think they have presented cases. I think migraine headache, either it could be a classical migraine headache or a non-classical headache. In children, I think it is very difficult. Say they can have bilateral symptoms, and a migraine headache can be associated with nausea, or it can be associated with photophobia or phonophobia. And usually they are sick looking and they don't do anything at that time. I think that will keep on recurring. Say over a period of time, you will be able to say that there are some migraine triggers and it lasts for some time, and whether it is relieved with drugs or not. Whereas tension headache, the child continues to be active. They have pain more, they complain pain more in the occipital region or in the neck or anywhere they like, but still continue, it doesn't disturb their daily routine or activity that much. And it can be attention seeking, or it can be related to, as they said, electronic media or some tension in the school or a psychological behavior of the child. Tension headaches are, I think, agreeing with Ramasamy sir, I would put cause of secondary headaches as infectious. Secondary headaches are more common first. Second, probably tension headaches. Third, probably you continue to see migraine headaches in children, and very, very rare to have what you said as a cluster headache. Cluster headache happens usually on one side. There is a tearing pain on the orbital region, extreme lacrimation. The child is sick for at least for 4 or 5 days. And this doesn't happen every day like migraine. Say it doesn't happen every 3 days or 4 days. It happens for a week or 5 days. The cluster headache can even last for 18 to 20 hours, unlike migraine. So, and these are very uncommon in children. Cluster headaches are very uncommon in children. And as I shared already, paracetamol doesn't do any good for cluster headaches. I think the treatment for cluster headaches probably in adults we give 12 liters of oxygen, and then we try a subcutaneous sumatriptan. I think that gives relief in cluster headaches, followed by verapamil. But that is very, very uncommon in children. I have hardly seen 2 or 3 cases in my career.
So in a child who we make a provisional diagnosis of migraine, is there a head-to-head comparison favoring flunarizine over a beta blocker, over ciprofloxacin, over imipramine, over sodium valproate, or it is basically the caring physician's choice? Is there evidence-based medicine to say this is the drug of choice and all other drugs should be compared to that?
No, caring physician's choice. I think if the recommendations are, you can try in children propranolol. The second, probably flunarizine group of drugs. Cyproheptadine probably third. And probably depending upon the physician's experience, either he can choose valproate or topiramate if he is not responding to these 3 primary drugs.
Fine, sir. And when do we start prevention therapy, sir? Who is a candidate for prophylaxis? Is one attack of migraine enough to start them on long-term management, or should we wait for a couple of events?
No, sir. It depends upon the individual child. If the headaches are incapacitating, it interferes with work or it interferes with schooling, and approximately maybe 4 to 5 episodes a month. So if it is going to exceed 4 to 5 episodes per month, these are the candidates who will be chosen for prophylactic therapy.
Perfect. Great. Thank you. Yes, you can proceed, Dr. Priyanka.
Ashwath, one question, whether this case can be a case of aseptic meningitis. Because started with fever, then again headache and vomiting was
But
going
fever
on.
was only for 1 day, no?
2 days.
2 days.
Just 2 days. The child is not febrile at admission. Admission is mainly for headache and vomiting. Do I read you right, Dr. Priyanka? The
Yes,
7
sir, yes.
episodes of vomiting.
Yeah.
The child was dehydrated and drained out. You can complete.
Yes, sir. On doing the blood workup, fever panel was found to be negative. Electrolytes were normal. LFT was normal, and X-ray PNS was done to rule out sinusitis. MRI brain showed normal findings. So after all this, the final diagnosis was since there were no clues pointing to any secondary headache on examination as well as lab. So we concluded it to be acute recurrent headache with migraine as a diagnosis, sir. And course in the hospital, we gave all the supportive care with fluids and supportive medications. And the child was also started on calcium channel blocker flunarizine 5 mg HS. And soon, like just after the first dose itself, the next day the child was showing an improvement. There was no headache or vomiting, and the child was then discharged with the same medication till the review, sir.
Dr. Priyanka?
Yes, sir.
In the supportive care, you mentioned Montelukast. Any particular reason why Montelukast was given for headache?
That was actually because the child also had some cold as well as dry cough. So we just started it as a supportive treatment, sir.
Because it's one of the most organizing complaints, complications, or side effects of glucotrain receptor antagonist is headache.
Yeah.
So
No,
in
actually,
the primary complaint is recurrent. I would think 20 before starting him on a glucotrain receptor antagonist.
Hallucination.
That
So
was mainly because of the.
It can cause headache. It can cause quite a few side effects. It is abused and used with proper indications, but in this particular case scenario, was a surprise.
What IV antiemetic was used, sir?
Ondansetron, sir.
Ondansetron itself can cause headache.
Just one comment about vomiting, Dr. Aswath, if you permit me. Dr. Aswath? Yeah.
Yes, sir. Yes, sir.
Any child that vomits, you replace the fluid that is vomited out and then identify the cause and treat. You see, as a general pediatrician, there is no place for anti-emetic medication. There are occasionally pediatric gastroenterologists use it just to ensure further episodes don't occur or prevent hospitalization, etc. But they have a very thorough physical examination very occasionally. But in general, any child that vomits, it's better to replace the fluid and not to give an anti-emetic in general of his practice or clinical practice or practice. So anti-emetics actually, you're all familiar with phenothiazine side effects. Phenothiazine, type of, the extrapyramidal reactions that occur after anti-emetic, unpredictable. And when that happens, usually they think an evil spirit has possessed, some Satan has possessed, and they don't come to you, they go to somebody else. The doctor thinking of tetanus or meningitis. That's the different type of diagnosis they make. So I'll be extremely, I don't touch anti-emetic at all in my practice. Maybe I'm saying it too far to the other side, but I don't think there's any rational. Okay. This is outside your topic. Okay. Yeah.
Thank you so much, sir. Can you wrap
that
up?
answers.
Thank you. Thanks a lot.
Thank you, sir.
I think
we have exhausted all the case materials that have been taken up for presentation over the past 2 hours, sir.
Wonderful, sir.
Yeah, thank you, sir. And on behalf of IAPTNC, really thankful to our today's moderators, Dr. M. Ramsamy and Dr. Pandian. Both are legends of pediatrics. And I thank our convener, Dr. Aswath Kuresami, who has done a tremendously good work past 2 hours. And I thank all the presenters, I think, throughout state, all areas they have represented and presented, and really helpful to all the pediatrician, really useful for them. Also, postgraduates also definitely will be useful. And any comments from others? Sir, Dr. MR, sir, your final comments, sir.
One brief question, can I ask?
But by and large, I would say, based on the headache is a rather uncommon complaint. compared to all the other symptoms in pediatric practice. Headache is rather uncommon complaint. That is number one. But when the headache is severe, when the headache is persistent, when the headache is progressive, and the headache associated with positive finding and physical exam, never ever ignore. Never ever ignore. So I repeat, severe headache, persistent headache, progressive headache, headache with a positive finding, either systemic finding like hypertension or neurological finding, you must pursue further to make sure the life-threatening causes of headache are excluded, namely intracranial pressure increase, hypertension, and meningitis, whether pyogenic tuberculosis. These are the life-threatening causes of headache that may come to ER. So these must be, they are uncommon, but nevertheless.
So one question, can I ask?
That's what I think. Hope Dr. Pandyan would agree. Yeah.
Yes, sir.
Please.
I will add bleeding, sir.
Yeah.
So sudden thunderclap headache, you can have a child with a bleed.
Correct. Absolutely. Bleeding. Yes.
And
how
always
how common, sir, the
visuals.
thunderclap headache in pediatrics, sir? How common, sir?
Maybe less common than in adults, but we have seen, sir.
But let me tell you, I hope.
And because AV malformations and which are missed can present to you as thunderclap headache bleed.
But there's one more condition you should keep in mind, which we have run into in our hospital: acute obstructive hydrocephalus. Acute obstructive hydrocephalus, either tuberculosis etiology or congenital acute obstructive hydrocephalus can present you with a headache, and that is a condition that we have run into, and it is very easily remediable nowadays with neurosurgical interventions and acute obstructive hydrocephalus.
Yeah,
that
thank
is
you,
there
sir.
in the differential
Thank you,
diagnosis.
sir. And now Dr. Kannan, a pediatric radiologist, he wants to. Yeah, any comment?
One final comment. The most of the MRI they mentioned actually no significant abnormality. So that's for a general radiologist. But if it's a pediatric headache, the pediatric migraine, some unidentified non-specific white matter signal change can be there. That can be a migraine related. And few prominent VR spaces or few arachnoids is also there. Now, actually, they come with the concept of clay lymphatic system in the brain. So it's like type of lymphatics in the brain. So it's a complex one, but it's how the fluids are maintained, how it's inflow in the along with the arteries and the interstitial space and along the veins. So if there is a problem in the clay lymphatic system, that can produce the VR spaces. So we are seeing some sister VR spaces. We are feel it's a non-specific. It's not specific. It's the recent paper says it's about the abnormality in the clay lymphatic systems in the brain. Especially they proved in the Alzheimer's, chronic hydrocephalus, these conditions, they prove the clay lymphatic system. So it's no significant abnormality in the brain. It's not, it means we are not understanding that much about the pediatric neuros. That's not our thinking, because it's an evolving field. And another one that idiopathic intracranial hypertension, yes, prominent optic nerve sheath will be there, and there can be the partial empty sella and the distal transverse sinus hypoplastic or stenotic. So acetazolamide can work. Now we are using the stents in that stenotic area also. And another one point, the MCA occlusion. Now the Western countries start practicing about the mechanical thrombectomy. So in the cath lab, we can remove the thrombus. So we are doing in the adult, but the Western countries, they are doing for pediatric also. So mechanical thrombectomy is also an effective method for this stroke. That's I want to
Thank you. I just want to ask one thing, if you don't mind.
Thank you very much.
We see a lot of functional GA disorders in children. We have a very clear classification of them. I just want to know, because we do have some associated headaches. I want to know from experts, headache in functional GA disorders.
It is.
Sir, Dr. Pandyan, sir.
I haven't reviewed literature to give you. I haven't reviewed the literature to give you additional information.
Particularly the abdominal migraine, cyclical, those are the things. That's the only thing I want to ask, because there's very significant.
Sir, they have been now they have now been, initially we thought they were part of the headache spectrum, but now they are separate entities by themselves. So we will have to rule out any significant identifiable organic cause, whether it is a cyclical vomiting or abdominal migraine or episodic migraine or episodic vertigo. All this, I think, now are taken off from the regular headache list, and they have to be considered as separate entities.
Thank you, sir. Thank you.
Thank you very much.
Thank you very much, sir. Thank you very much, sir. I think we have had a very nice discussion about common headache. I still believe that we are still obsessed with our rare causes rather than the common causes. So, though we have achieved our aim to some extent, we are still struggling to kind of meet the aim of the CAPSULES series. But I think it's still like a process, and so I thank our APS coordinator, Dr. Rajendran sir, our program coordinator, Dr. Rashwat sir, all the regional coordinators, Dr. Palniram, Dr. Sridevi, Dr. Balaji, and Dr. Raju sir, and most importantly, the experts, Dr. Pandian and MR sir, for making for the valuable inputs and clarifying many of the common doubts which we don't, answers for which we don't get in textbooks. So thank you very much, sir, for spending your time with us. This program wouldn't have been a success but for the enthusiastic presenters from the various institutes. So my special thanks to them. My last but not the least is to all the people who have participated actively, and I really thank each and every one of them on behalf of myself and the president, and on behalf of IAPT MSc. Thank you, one and all. So hope to meet you next month. Thank you. Good night.
Thank you, sir. Thank you.